Thursday morning here, or morning, I'm a little bit behind. Oh, Thursday afternoon in Spokane, at least that's where I'm calling in from. I'm here with our contingency management training team from Washington State University, and I'll introduce them later. But I want to welcome you all. We're really excited to be here with you all virtually, and especially as I see all the folks chiming in roll from around the state. So yes, please, as you join us, chat out your name and your affiliation, where you're calling in from. And we're going to go ahead and get started. First, I want to get started with just sort of in a good way and acknowledge that we're all calling in from different parts of what we now call Washington State. But these are the original homelands of the indigenous peoples of this area, including many of us live in places that are named after those tribes and communities, including Spokane, where I'm calling in from. So I just want to recognize those folks and talk to you today. Later, we're going to talk a little bit about serving tribal communities, because that is a big chunk of our work that we do in contingency management, is in partnership with tribal communities. So we'll talk a little bit more, and we talk about cultural factors in contingency management. But with that, we'll get started. So let's see, I've got 3 monitors going here, so I want to make sure I click on the right one. So first, introduce our team. I'm Mike McDonald. I am a professor and clinical psychologist in the Elsa S. Floyd College of Medicine here in Spokane, Washington. I have been doing contingency management research for the last 12 years, both in Seattle, Spokane, and then in our work in Native communities throughout the country. And I am also still an affiliate professor in the Department of Psychiatry. So I work closely with a lot of our colleagues, some of whom are on the call at ADAI. But really we're here, our team's here to talk about specifically contingency management. So I'll just ask people to wave as the rest of our teammates to wave as they're introduced. So I want to introduce Dr. Sarah Parent, who is our lead contingency management trainer. She's a naturopathic doctor by training. She's an assistant clinical professor in our department. And she's really, when it comes to contingency management, Sarah knows it in and out. And she's going to lead our nuts and bolts training, which is going to be our training next week. And then really help support you all in implementing as we go forward. I'm also excited to have a new member of our team join our training team. I've worked with Dr. Andre Miguel for a long time. And so welcome, Andre. Andre is a clinical psychologist and an assistant research professor. And Andre has been doing work just like the work you all are going to do for years in Brazil. So Andre has been implementing contingency management for stimulant use disorders in Brazil for a long time, and has a lot of rich experience doing that work in really low resource settings with challenging patients. So we're excited to have Andre join our team. Another person who you'll be working with as we go forward in this groundbreaking initiative, because really, I hope you all know this is totally a groundbreaking initiative. Outside of the Veterans Administration, only one state at a state level is implementing contingency management in a way that's really based on the research evidence, and that's Montana. And as some of you might know, California has a newly funded $58 million implementation of contingency management, but they haven't started. So we are in second place. My wife's Canadian. I joke that we're in the Canadian spot. We're in second place behind Montana a little bit, but we are, and we've learned a lot from our work with Montana. And we are now, but we are ahead of California in terms of you all implementing and the state being so supportive of us implementing contingency management to help people with psychostimulant use.
Oh, Nagazi.
So thank you. I think the person who was just chatting muted yourself. So that reminds me, yeah, everybody, if you, as you jump on, if you could mute. The last person I want to introduce, although it sounds like she's not able to make it today, is Rachel Shin, who's a clinical social worker and one of our staff who implements contingency management in one of our studies and is an expert in contingency management as well. So that's that. So we also just want to talk about a couple of things before we get started in earnest with the training. First is we have no disclosures. Our team is doing training in different states. We have no disclosures to report. We've already talked about doing the chat. The other thing I wanted to say is we are going to be recording because we know that you may all have a hard time sleeping some night and need to go back and has something help you put you to sleep, you might want to listen to this later. Or you'll have colleagues on your team who weren't able to make it today. We want to make sure they have access to this information. And as you hire new staff and bring on new staff over the next year, we're hoping they could watch this too. So we're going to go ahead and record this training, and all the other trainings we'll be doing with you all. Now, so that's exciting news recording. More exciting news is we're going to give you a test. We're going to start with a test. So Sarah's going to put in the chat a quick contingency management pre and post test. Now, it's really important that you don't worry about how well you do on the pre-test. We don't want you to do that well on the pre-test. So don't worry about, answer the questions quickly, give it your best shot, but this will really help us. We're going to give you the same test after the training's over. Again, not to, test you like we're teachers, but to really understand, how well our training is going, and really to get that feedback in terms of the what you're learning. So if we're going to take the next 5 minutes, so it's 1:09, so let's take till 1:14 to have you all just quickly go and fill out that survey. That'll be really fantastic. And let us know, chat us any questions if you have any. Oh, but we can't help you with the test. So, but if you're having any issues accessing it, filling it out, let us know.
I love it that somebody chatted that the questions are really easy because it's just your age, gender, and location. Yeah, hopefully, if some of you have gotten through the process now, you will get sent to a page that's just a demographic survey. It does involve putting in your email address, and then the email, then it'll pop you an email with the actual content survey. So if you're not near your email right now in a convenient way, we understand, but if anybody, if you do have the ability to do it, that would be great. Thank you.
Thank you, Sarah. I didn't realize that. I thought it was all like one slick form. So yeah, folks, if you don't have a chance to do it now, that's totally fine. We'll give folks who are more tech savvy than I am a couple minutes to fill it out if you're still working on it. But if you please could, even if it's after the training, fill that out. That would really help us out a lot. And it should really only take you less than 5 minutes or so.
I don't normally work from home, and my puppy is so excited to hear a voice behind a door that he doesn't usually hear this time of day. So if you hear a dog in the background, that will be why.
Thanks, Sarah. I understand that, as you know. So that's why I'm at work. So anyway, so we Lindsay, I think, and trying to find the comment here. The Stephanie chatted, can someone email Chrissy at Capital Recovery Center, the Zoom link? And so I don't know, Stephanie, if Lindsay, the question is, do you have that person's contact information from the invite? And Stephanie, could you, could you share that person's email so we could send them that Zoom link?
Mike, this is Amy. Megan can forward that email.
Okay, perfect. Thank you, Amy. Oh, there it says right there, Megan. Thank you, Megan. I'm a little slow on the chats. Okay, so we're gonna go ahead and get started. If you're finishing up that survey, you know, you take a couple minutes to finish it up. Hopefully, as we're getting started. If you want to take a pause and just listen, go ahead and just take a pause. If you're like me and you didn't even check your email to get the link, because then don't worry about it. Please, if you could fill it out later, that would be wonderful. So I want to go ahead and just get us started though. So the first thing is we've been using this chat, and while I'm presenting, Sarah's and Andrea are gonna monitor the chat to respond to your questions. So if there's questions you've got, chat them out. And this talk today, or this workshop today, is really intended to just give you an overview of what contingency management is, what the research is behind it, but it's not enough to go out and implement contingency management by yourself. That's going to be next week's training. Next week's training is where Sarah's going to lead that training. It's going to be focused on what we call nuts and bolts, exactly how to track how to do contingency management, how to do the model that we're going to teach you, that we're going to be implementing throughout the state together, and is really going to set you up to be ready to go in terms of implementing contingency management. So please chat your questions now. We'll try to respond to them if it's clear in the chat. If it's clear that one of us needs to take a pause and just sort of restate something or repeat it, we'll go ahead and do that. And we'll also hopefully have time for questions at the end. Any questions that we're not able to answer, please send them to Amy and her team, and they'll get them to us, and we'll be glad to answer those over email if we don't have time today, or we'll have plenty of time for discussion in our longer training next week. So, but let's start with just chatting those questions, any questions you have. Okay. So again, the overview is today. Nuts and bolts is going to be next Tuesday from 8 to noon. We're going to record all of these. You're going to receive 2 other pieces that are super helpful things from our team later this week. The first is going to be what we call the voucher tracker. And that's something that really helps you track the prizes or the rewards that we give to people, or the vouchers we give to people. And so it does a bunch of things. It helps you do the math on how much a person's supposed to get in terms of their voucher. And it also helps you document that you're giving those vouchers out, or those rewards out, for negative urine tests, which is really important. And we're going to talk about why that's so important from an auditing and sort of compliance perspective. We're also going to send you our latest and greatest contingency management for stimulant use disorder manual that describes all the stuff that we're covering in the trainings in nitty-gritty detail. So we'll be sending those 2 things to you later this week. If you have a chance to review those materials, especially the manual before we have our training next Thursday, our nuts and bolts training, that would be wonderful. That'd be great, because that would really help you stay ahead. And then after that, we're not going to just leave you hanging. We have worked with HCA, and we're going to be helping you all in terms of ongoing coaching and fidelity monitoring to make sure that you feel supported in implementing contingency management. Because again, we're breaking new ground here. Just like the state has broken new ground in the work that a lot of you are doing in buprenorphine, or the work you all are doing in jails in partnership with outpatient providers, this is really breaking new ground. Again, very few places are implementing contingency management. I'll talk about why that's true later, And it's the hot topic right now because it's really one of the best tools we have for treating stimulant use disorders. Last, I just mentioned you all are working on potentially editing contracts and editing other stuff, or finalizing your contracts, or you've already finalized your contracts with HCA. They're stepping up, HCA is stepping up and going to support you with funding to actually fund the incentives, because that's been one of the major barriers to contingency management. So the model we're training you all to do and the incentive amounts we're recommending you use are consistent with the contracts that you all should are establishing with HCA. So thank you, HCA, for stepping up. The last thing I want to mention is we'll be doing this in collaboration. We have some colleagues on the line from ADAI, our good friends and colleagues over there. And so we want to make sure you all know that for those of you who work with ADAI through SOAR and through other sort of technical support resources that they provide, that we are going to coordinate so that we're all working together and supporting you. So they're going to continue to do their great work that they're doing with you all. We're going to focus on contingency management specific, but know that we are also talking to one another to make sure we're supporting you as you do this really important public health work. So our goals for today are to describe the current methamphetamine use crisis, which you probably can describe me to be us. We don't need to describe it to you, so we'll spend a little time on that. And then we're also going to describe positive reinforcement and how it's used to reinforce stimulant abstinence and contingency management. That's sort of what contingency management's all about. We'll be able to, you should be able to identify the 3 components, or as Sarah calls them, the secret sauce of contingency management that makes it different than regular incentives, that makes it different than just an incentive intervention. And you should be able to summarize generally the research support for contingency management for stimulant use disorders. Okay, so quickly, again, you all know what's happening. That's why you're here on this call, I'm assuming, is that you know what's happening with methamphetamine in the methamphetamine use disorder, methamphetamine use kind of crisis or epidemic we're experiencing. So these are data from a national data set on overdose counts. And what the thing to really keep in mind here is just the change from 2020 to 2019. So these are relatively recent data. Our state has even more recent data, which are concerning in terms of people dying. I'm sorry, we're trying to move to new language and talk about poisonings, not overdose, but I see this slide still has overdose in it. So these are people who have died from, and in the change, the percentage change here is important to keep a number. I mean, it's important to look at the numbers because those numbers are scary and they are so much higher than we've ever experienced before. As many of you know, the number was 100,000 for last year. People died by drug poisonings. And so we have to, this is a public health crisis. You all know that. We've got to move our treatment minds out of, and a lot of you are already doing this work, but we need to move our treatment minds out of how do we treat people who show up to our offices, and how do we help more of these people? How do we intervene with more folks so that we can get them into treatment, that we can offer them a product they're excited about, that we can offer them something that people want to go to treatment, that they're not just mandated to go to treatment. So I think contingency management's one way that we could do that. I know the work that you all are doing already is really outstanding. So Joshua, the answer to your question is yes, these are nationwide statistics comparing these 2 years. So what you can see, these are just changes. I want you just to look at changes of deaths by overdose from the 1 year to the next year. And it's a shocking, already high number, 68,000. There's an overall change of 21%, but this change is being driven by synthetic opioids, which are fentanyl, and then also by other psychostimulants, which means meth. But you can also see this cocaine number is higher too. So in our state, I think last year, and the HCA team can correct me if I'm wrong, or the ADI team, I think we saw, if we looked at just one, at least the data from last year, if we looked at single death poisonings, methamphetamine was actually starting to exceed fentanyl. Now, of course, many people died from both, using both at once, and that's sort of what we're dealing with, and why this is so important, the work that you're doing and adding contingency management for stimulants. But really, we're seeing a methamphetamine level of potency in methamphetamine and use of methamphetamine and death from methamphetamine we just haven't seen in the past. So the other thing that's relevant to all of our work is, who's not only who comes to treatment, but who stays in treatment. So again, colleagues the team at ADI, led by Caleb, Anta Green, and others have published data, such and other people around the country have published similar data saying that relative to people who use opioids, people who use stimulants are less interested in treatment. But they're also less likely to stay in treatment. So when you look at the attrition rate here in this study, or this, I think this was a meta-analysis. So I think this, yeah, it was a systematic review. So this is like adding all the studies that have been done together. We see is a very high rate of attrition. And again, I don't need to explain this to you probably. You see this in probably your day-to-day lives as providers. So people who use methamphetamine are more likely to drop out of treatment. And then, of course, many of you are either prescribing buprenorphine, part of a team that's using buprenorphine to treat opiate use disorders, or maybe methadone, or you're working in a jail where you have a close link, or you continue people on buprenorphine, or you send them to buprenorphine team that you work with when they're discharged or they leave jail or prison. So that's great. Buprenorphine is amazing. Methadone is an effective medication, has a lot of data to support its efficacy. Those things save people's lives. We don't have that for stimulant use disorder. We don't have an FDA approved medication for stimulant use disorder. There's a lot of really exciting evidence or research going on now, including over in Seattle, looking at other options for medications. And there's a lot of focus in the research world on that now, but we don't have that. We don't have that smoking gun like we have with buprenorphine, for instance. We have some moderate evidence that cognitive behavioral therapies, particularly those that are tailored towards stimulant use disorder, have some sort of an impact on stimulant, have positive outcomes on abstinence for people who have stimulant use disorder. And contingency management has substantial, consistent evidence that it can do two things: do better at retaining people with stimulant use disorders in treatment, and can increase their odds of abstinence. That can reduce use and improve abstinence. So, and then, but for the most part, and it's not universally true, many of you may be doing work like CBT for CBT or other cognitive behavioral therapies for stimulant use disorders, but for the most part, there's very low penetration of evidence-based interventions for stimulant use disorder. So much like 20 years ago with buprenorphine not being widely available in our state, evidence-based interventions are not really widely available for stimulant use disorders. And we're here, obviously all here today to start continue to work on solving that as a problem, to make those interventions more available. So now I'm gonna turn it over to Dr. Parent, and Sarah, you can take it away.
Great, thank you, Mike. So I want to just introduce what is contingency management and how does it work, and just know that these are going to be the very, very basic concepts, and we're going to dig into all of these in detail next week. So I do, Mike, if you could move on to the next slide, I do want to start you off with bringing you back to your Psych 101 class, probably freshman year, where you learned about B.F. Skinner and operant conditioning. And the reason why we're going to review this is what contingency management is based on. And for me, learning this is what helped me realize that contingency management, that there's a method to this madness, that it isn't just bribing people to stop using substances, but that there is it's a therapeutic intervention, and based on this theory of operant conditioning. So just to review, operant conditioning means that every behavior has a consequence, and then that consequence will drive behavior change. And so you can either drive behavior change with positive or negative reinforcement or punishment. And so just to review those terms, positive means adding a stimulus. So it's not good or bad. These aren't value judgments. This is just adding a stimulus. And then negative means removing a stimulus. And then reinforcement is when you want a behavior to increase or be maintained. And then punishment is when you want a behavior to decrease. So all of these things change behavior, but I want you to just focus on positive reinforcement, because that is what contingency management is based on. So we are going to therapeutically add a pleasant stimulus to increase or maintain a behavior, and that behavior, spoiler alert, is stimulant abstinence. So keep that in mind, and as we go forward, and Mike, you can move on to the next slide. Because so substances themselves, and yeah, just to review, so both reinforcement and punishment change behavior. We know that, and to this point in the world of substance use, we all know that punishment has been used quite often, right? So that, you know, the fact that the legal system is very much involved in stimulant use, you know, I can't even call that a treatment for stimulant use disorder, but a consequence of using stimulants. And so we're very much used to a punishment based model for substance use. But remember, both do change behaviors, but people tend to respond to and prefer reinforcement, right? Because that is going to teach people what to do. It teaches that new behavior rather than just teaching what not to do. And then punishers, especially the legal system, lack that immediacy to be effective in any kind of operant conditioning way. So, you know, you may get caught using or possessing a substance, and then that punishment happens months down the line. Punishment has unnecessary side effects, shame, guilt, moral judgments. And so positive reinforcement, it teaches that new behavior, reinforces that new behavior in a way that builds self-esteem and self-efficacy. And Mike, if you could move on to the next slide. And the other reason, though, that talking about operant conditioning is so relevant to talking about treating substance use disorder is that the substances themselves are also employ a reinforcement or an operant conditioning. And so psychoactive drugs feel good when people take them. And so that creates its own positive reinforcement, right? You're more likely to do it again because it felt good the first time. They may also remove negative feelings. That's what actually what negative reinforcement is. So removing negative feelings, you know, stress or trauma or unpleasant environment that somebody may have to deal with day in, day out, that psychoactive drug kind of helps them get through that. And so again, it creates a reinforcement. It makes it the person more likely to use the substance again. And so as drug use progresses, as substance use disorder takes hold, then that drug use may actually be the most reinforcing thing in the person's life. So other things that are reinforcing, like feeling good about a job well done or having rewarding relationships with family and friends, these things start to go away. And the only thing left that makes somebody feel good is that substance. And so knowing that the stimulant drugs themselves are so highly reinforcing and that we describe this as hijacking the reward pathway in our brain, right? So the brain is only feeling rewards through that substance use. And what we need to do with contingency management is create a different positive stimulus that can kind of compete with the reinforcing nature of the substance and kind of get the reward pathway back online so that eventually other naturally rewarding experiences in life can also continue to provide other reinforcers. So next slide, please. So a number of experiments have been done to show, well, okay, this sounds great in theory, you know, operant conditioning exists, but does it really work? Does somebody who used substances, would they really choose another positive stimulants over the drug? Or do we think the drug is just so powerful that they would never choose anything else? Well, so they did some experiments. This study always makes me smile because I can't imagine asking the IRB to give out lines of cocaine, but that's what they did. So they had research participants come on in. They were able to provide, and these were people who used cocaine. So it wasn't, you know, it was people who were already inclined to that choice. And they presented them with lines of cocaine or money. And you can see pretty clearly here that if the money was only 5 cents, and I think this was back in the 90s, so you can, you know, do some math for some inflation or, you know, more inflation. But you can see when it was 5 cents, 8 out of 10 people still chose the line of cocaine, but all it took is up to $2. And now you can see 2 out of 10 people chose the line of cocaine, and the rest chose the $2. So this shows that, that people who use substances, who use stimulants, are rational people and can still choose other positive and rewarding and reinforcing experiences in their life. And it doesn't necessarily need to be a lot of money. So Mike, if you can move on to the next slide. So this is the real basics of contingency management. You look at a behavior. So in this case, we're going to tell you that behavior is it's stimulant abstinence as measured by a stimulant negative urine drug test. You give somebody a tangible reward, and then you see that behavior increase. So they're more likely to be able to submit a stimulant negative urine drug test the next time. So it's that simple. And then we're going to be teaching you the details to really make sure that this program is well organized, that it's using reinforcement in the best way that research has been able to kind of show which details are more likely to have this occur predictably. So next slide, please. So here are the key elements of contingency management. And again, I'm going to be teaching a lot of kind of drilling down on each of these bullet points next week, but I just want to give you the big picture here. And this, again, is what sets contingency management apart from more, say, a generic incentive systems. Like incentive systems exist in a lot of places. You could get, a little gift card for filling out a survey. You can get a certificate for completing something. There are plenty of ways to reward somebody for a one-time behavior, but when you want to see a behavior increase and be maintained over time, then we want to use these details in contingency management. So that target behavior that you're going to want to see maintained or increased, you need something that can be measured objectively. And that can, again, is measured. So it's not something like a self-report. It needs to be a behavior that is achievable, which means that, if you're going to ask somebody that has never run before that they need to run a marathon by the end of the month, that's not going to be an achievable goal, right? So you need something that can be achieved and in a time frame where somebody can be experience a reward early on. And then, of course, you need something that's feasible, right? So, a behavior such as stimulant abstinence measured by a urine drug test. This is a feasible test that can be administered by just about anybody. It's not prohibitively expensive. And then you also need a target behavior that can be measured consistently. So even back to the marathon example, you wouldn't, if the marathon itself was the behavior you're looking for, well, you're not going to run a marathon every week or every day. Most of you probably aren't. And so that's not something that you could reward consistently. It's going to take a long time, and then it might be kind of a one-time or very infrequent thing. So we want something that we can notice, measure, and observe frequently. And then we want to reward it, right? That's the whole idea of contingency management, is that we are going to reward the behavior, but that's going to provide that positive stimulants, right? So what is a reward? So the reward itself needs to be contingent. That's right in the name, but just to make sure we all know what that means, it means that you only give the reward when the target behavior has been observed, right? So it is contingent upon observing that target behavior. And then we want that reward to be immediate. Remember, we're doing operant conditioning. I think of, sort of a dog training example, that you can't give the treat to the dog tomorrow when they did the behavior today, right? So you want to really be able to pair that behavior choice with the positive outcome. And then we recommend that rewards are tangible, something that in no uncertain terms the person feels rewarded, that it is in their hands, that it isn't just a smile from you, which is also a rewarding experience that they may receive from being in your contingency management program. But we want it to be more than that. We want it to be something strong enough and desirable enough to compete with that reinforcing nature of the stimulant substance. And so again, yes, the next bullet is that it needs to be desirable. And then we'll also teach you that we recommend that it is escalating, that those rewards get bigger over time as the behavior is maintained over time. So as somebody achieves longer and longer durations of abstinence. Next slide, please. Okay, and so a little more details on the target behavior. So in a stimulant contingency management program for stimulant use disorder or stimulant use, stimulant abstinence is our target behavior as measured with a stimulant negative urine drug test. So we want your program to stay focused. We don't want you to require abstinence from other substances. We need that behavior to be objective. We just talked about that. We need it to be achievable. So when you use a point of care urine drug test, as a detection window of about 2 to 4 days for being able to detect stimulant use. And so that is an achievable goal, to be able to be abstinent for just a handful of days to receive your first reward. And then these point of care urine tests are also feasible. They're cheap, they provide immediate results. Again, anybody can be taught how to read those results. You don't need specialized lab training. And then you want to measure that target behavior consistently. And so it is very feasible to be able to do urine drug tests twice a week. Next slide, please, Mike. And then remember the rewards. So they need to be contingent. Only provide a reward when that urine drug test is stimulant negative, right? That's what contingent means. They need to be immediate. So you reward right after that urine drug test. And again, that the fact that the test can be read immediately and the fact that you can have that reward available immediately is part of what's going to really make that contingency management more powerful. You want tangible rewards. So gift cards tend to be the most desirable tangible rewards. You could also use prizes. And then you want to make sure that your contingency management clients and patients want those rewards, right? They have to be motivating and interesting to them. So that's something I'll teach you next week about how to put some thought into it. But in general, we want that first reward, you know, the one that they're working for that first day, to be high enough to be interesting. And so right now we would like to recommend that you use a $10 value for your first reward that you'll be giving out. And then we think your program should be at least $500. If somebody was continually abstinent for an entire 12-week treatment period, they could earn at least $500. And that makes the whole program at a magnitude that is more consistent with the research. And then again, I'm going to give you a few more details about how the escalation is important, how those rewards should get bigger the longer the client or patient is abstinent. So next slide, please. And then this is what Mike said, the 3 elements of contingency management that really set it apart. I like to call it the special sauce. So escalation, reset, and recovery. This takes a little time to learn and wrap your head around. So I'm just going to introduce it now, and then we're going to dig into it next week. Escalation means earning bonus rewards with continuous abstinence. So the longer somebody is abstinent, the more rewards they'll earn. We do also, though, use something called reset, which means now we already know that the rewards are contingent. So if somebody turns in a stimulant positive urine drug test, or they don't come that day, they miss giving the sample at all, then they're not going to get rewards. And then the next time they are going to reset down to whatever that initial reward level was. So they will basically temporarily have their bonus rewards suspended. But then, of course, you know, there's positive reinforcement. Positivity in general is at the heart of contingency management. We don't want a little slip up to turn into giving up. And so we use this system called recovery, which means that somebody can recover all the bonus rewards they had already earned. In other words, they can earn back up at the level that they were previous to their reset with only 1 more week of abstinence. So I always explain that as they don't have to climb the ladder 1 rung at a time again. They will just get right back up to the level they were before. And I'll explain why this system is in place, but and just to let you know that a lot of research went into showing that this is really a great way to make contingency management more powerful and effective. And so it takes a little extra to learn, but it's worth it. And with that, I am going to pause, see if there's any questions, and I think pass it back to Mike.
Gotta unmute myself. So we had a really great question from Anna Taylor. What if we aren't allowed to offer at least $500 per the grants and incentives? So I pinged back an answer, and Amy and team can correct me if I'm wrong, but that's something we've been talking about and we've learned in our work in Montana. So what I think we're all in agreement that we're going to, you all are going to be able to do the full $500, but remember that your average patient will only earn about, if we set the maximum at 500, your average patient will probably only earn about $200 to $300 in incentives. And that's because it's not perfect, right? If it worked so great, if it worked perfectly for everyone, then that would be wonderful. But a lot of people won't make it to every urine test, so they can't earn a voucher if they don't show up to a urine test for the most part. There's some exceptions. And they won't submit a negative urine test every time. So what we find in all of our work is that if we budget for a maximum voucher value of 500 over 12 weeks, we typically see people on the average patient or client earn 250, half that amount. So $250 to $300. So,
yeah, or you can also think of that program wide, right? So actually some people may earn the max, and then some people may earn almost nothing or nothing, right? So there will be people who drop out of the program early, or again, struggle to achieve, the abstinence. And then there'll be people who are knocking it out of the park and show up every single time and get every single reward. So over, if you average it over your entire CM client base, then you'll usually hit that middle mark there. And what Mike described, also people earning some of the rewards, is sort of a strength of contingency management too. They're not going to get kicked out right away if they, don't earn rewards every single time. They are going to stay in, many will stay in the program and earn, less than the max total possible, but somewhere in between. So.
Thank you, Amy.
Yeah, I just wanted to add on to that. Luckily, we've been piloting the State Hub and Spoke project with WSU and the Contingency Management project. And what I know is that the money is there. It's just that things have been changing rapidly around the amounts that the money is there. We just may need to change the contract language in order to allow it to be up to $500. So luckily that's a good, it's good that the money's there. We just have to keep changing things in order to keep up with what's best practice. So more to come on that from your contract managers as we get closer.
Thank you, Amy. And thank you so much for your support on that, and your whole team, Linda, everybody on the team, and Stephanie. Like, I think so just jumping a little ahead, 3 years ago, right before the pandemic, a bunch of our colleagues went to SAMHSA, and because SAMHSA said, whoa, people are using a lot of methamphetamine. We need to do something about this. What can we do? Especially folks who are receiving medications for opiate use disorder. And so our contingency management expert colleagues went and they met with SAMHSA, the director, and they said, oh, here's what we need to do. We need to do contingency management. We need to do it $500 incentives and blah, blah, blah. And they were really happy about that meeting. And then the next couple of weeks later, SAMHSA said, you can spend $75 on incentives. And so we were like, oh, that's not enough. That would be like, you can give each patient 2 pills of buprenorphine. So, and that's it. And so we were like, well, that's not the right dose. So and then last year, Montana approached us and said, we think we could take that $75 and add some tax money. We think we can do 300. And so we started doing that work. And what we've realized as a team, as a larger group of national experts in contingency management, is that we really got to be at that 500 number, maximum dose that a person could receive over the 12 weeks. And so I really want to say thank you again to the whole HCA team, and then also thank you to you and your contract managers at each one of the sites, because we're going to ask you to, we're hoping that you all can work with HCA to slightly modify that contract language so we can do exactly what we'd like to do, which is make sure everybody gets the effective dose of this intervention. Does that make sense? Any other questions about that before we go on? but no detailed contracting questions. Okay, so keep those great questions coming. They're fantastic. We are going to talk about just models. There's a bunch of models of contingency management. There's some really cool models around, take-home doses. For any of you who, before the pandemic, were working in methadone, there's a contingency management model where you can have extra take-home doses from methadone take-home doses if you're stimulant abstinent in methadone. There's a therapeutic workplace option where you can submit a urine test, and if it's negative, you get to work and earn a living wage. There's all kinds of different contingency management models, but there's two main models that can be added on to either outpatient addiction treatment, like a standard IOP kind of a model, or counseling model in an agency, or it could be easily added onto an, well, I'll be careful with the word easily, added onto an office-based buprenorphine program, or more of an office medical-based setting. So they're really in ambulatory models of contingency management. So the two are, and the first one is the voucher system. And we are going to teach you a voucher model of contingency management. And the only difference between the two models I'm going to talk about is the way they do the incentives, the tangible incentives. And they both cost the same amount of money. They're both equally effective. But one we think is just much easier to explain and keep track of and use. And so the voucher model is where is again, $10. We start that first urine test. I know when I come in that if I submit that first negative urine test, I get $10. And I know every week of abstinence, every 2 urine tests in a row that I'm abstinent, I'm gonna get an extra $2. And that's gonna keep adding on over the 12 weeks if I'm abstinent the whole time. So I'm gonna have a pretty, but every week I know it's the dollar amount that I know the dollar amount I'm gonna get based on my urine test result. So the client knows and the clinician knows. And we can bank those vouchers, which we now typically just use gift cards. When they did vouchers, like actual vouchers in Vermont when they developed contingency management. But we're actually going to suggest using gift cards because they're easy to use and people really find them reinforcing. But vouchers can be banked, which we'll talk about later. In Prize CM, if any of you have heard of Prize CM, or you've heard of the fishbowl or the token CM, contingency management, first of all, the full disclaimer is we're going to teach you vouchers, but in all of our research, we use the Prize CM. So Sarah's big study that she's doing in Washington, both here in Spokane and Seattle, we use this prize system. I've used the prize system forever. It's a lot of fun. So the way it works is that instead of the dollar amounts going up, it's number of draws you get into this prize bucket. You can see some of the tokens here on the bottom of your screen. Half the tokens just say, good job, woo! And it's just like an encouraging phrase. Some of 42% of them, you get a $1 prize. And about 8% of them, you pull a token that says large, you get a $20 prize. 1 out of 500, you are so fired up. You give high fives, you run around the clinic screaming, jumping with joy because you get a $100 prize. That's the jumbo token. And so what's fun about this is it's kind of like, you never know exactly how much you're going to get rewarded with. So, but what happens is it works the same way though. You start with maybe 5 draws, and every week of abstinence, you get a bonus draw. So your draws go up and then they are reset. But that's a system. It's fun. Is it more effective than the voucher-based model? No. Is it cheaper? It turns out it's not. So, and we think it's easier to do the voucher-based model. And so we're going to go ahead and teach you that. So, but we want to make sure you know about the two models. Will we go into details? The question was, oh, you answered it. Say, Sarah. Okay, so I'm going to try to pull off unsharing my screen. I'm just going to show you how simple a contingency management visit is. We are going to show you, this is a video from our clinic in Belltown from maybe 10 years ago. And this is a video of one of our staff members doing contingency management with actual participants from our study at that time. And it just sort of shows you how simple it is. It is the prize-based model, which you'll see kind of how that works, which is fun. And so I'm going to stop my screen share and I'm going to find my browser. Oops, no, you don't. And let's see if I can pull this off. Uh-oh. Sorry, everybody, I'm having some technical issues. Feel free to chat questions to Sarah and Andre, our team, while trying to figure this out.
You have a utility meter like this on the side of your house, you could get
Sorry, I'm
paid
watching
for
an ad
solar
on YouTube
for
first,
no
so you
money
don't
out
need
of
to
pocket.
hear. Okay. So I'm gonna blow that up. Zoom screen. All right, you all should see my YouTube. Do you see my YouTube, Sarah? All right, great. All right, so this is a quick video. Maybe Sarah could chat this link, and if you can't see it, if you're on the phone or not able to see it, we could chat this out to you. It's only 2 seconds, so this shows you the whole contingency management visit, so you get a sense of how simple this really is in terms of an intervention and how much fun.
Today by having you do a UA.
Okay.
So if you don't mind, we'll just have you take this and
Okay.
stand up and just head out that way.
Okay, I can do that.
Great. Great, Paul. Thank you so much. So we are going to check this here. How's your day been?
Pretty good.
Good, good. So now we're looking to see you are clean for cocaine, amphetamines, methamphetamines, THC, and heroin. So it means you've been in the study for 4 weeks. That means you get 5 draws. Sound good?
Yeah, sounds good.
Excellent.
All right.
Okay. Let me shake our big bucket.
All right.
Okay, first draw. What do you got?
Small.
Good job.
All right.
Nice. Go back in there. What's this?
Small.
Small. Great. Good job. We're back to 2 smalls.
Can we get a different
Keep
color?
going. What's this?
Large!
Hey,
Hey,
good job.
alrighty, that's the ones I
Excellent.
like.
Good job. So that's 2 smalls and a large. So we'll stand up here and
Okay,
have you look at our cabinet.
okay. Alright.
There we go. Sorry, got a closed door.
Oh, hey.
And grab yourself 2 smalls and a large prize.
Okay, small here?
Mm-hmm.
Okay. Oh, wow. What a decision. I don't need any more mac and cheese, huh? Oh, I'll take 2 kids. Oh, where's these? Oh, no. This, the lips. I'll
Excellent.
take lips. Okay,
And you
and
can get another small too.
so one more small. Is that a whole cup full of goodies? or
Oh, they're just 1 each.
Just one each, okay. Oh, well, oops. I'll take the gloves.
Great.
Can use
Excellent.
those this time of year, okay.
And a large?
And a large, is that this shelf?
Yep, that's that second shelf.
That's that one there, okay. What is this here? Oh, we'll take this one.
Fantastic.
Okay.
All right, so that's literally how simple it is. And again, this is the prize-based version, so you can see you have to have an inventory for the prizes. And then you have to have the ability to do the prize draws, which is a little bit dicey with COVID. And you have to, but you can see how much fun it is. And you can see how excited our participants are these folks are in the study, and how excited the clinician is. I want to apologize for some of the language. We wouldn't encourage people to use the term clean in terms of talking about urine tests. We talk about either it's positive or negative. But you get a sense from that sort of the spirit of the intervention and really how simple it is. The complicating factor being how to track the number of vouchers or prize draws any person gets at any particular time. You can also see that we are operating out of a very small psychotherapy office or counseling office, and this was done in collaboration with the Community Mental Health Center in Seattle. And so you can see, how small of a space we can operate in. And obviously, if you're using gift cards, you can do this out of any office or any space that you already have access to. So, all right, I'm going to try to make sure I get my share back going here. All right, and Sarah, can you see my slides? Okay, So I know we're not being super interactive. Please keep chatting those questions. Our intention is for the longer training, for sure, to have an significant interactive components. So please keep chatting those questions. And we're gonna talk about the research evidence. The take home point for contingency management is that it has so much evidence, especially for stimulant use disorders, that it is the best way to help people establish abstinence from stimulants. That doesn't mean permanent abstinence for the rest of their lives. It might mean that they reduce their use. It might mean some people do come in and they establish abstinence. They get super fired up about the prizes, or the incentives. They're committed to stopping, and they stop. And in the first, just like in their intervention that you might offer them, they respond, and they're abstinent. Like the woman who was pulling the prize, doing the prize draw, getting the prizes at the end. That was 18 months that she'd been abstinent after she was in the study. And again, that was intervention targeting stimulant use disorders in folks with serious mental illness. And so she was abstinent. It worked for her, worked great for her. Some people, they're not abstinent consistently, but it reduces their use and it keeps them in treatment relative to folks who wouldn't receive it. And then the side effect of all that is it really brings a positive environment to your treatment program. It really builds on any positive environment you already have. If you're struggling with positivity, especially with burnout and workforce, this is really something fun that brings a positive, even improves the positivity of your clinic, both for you all as clinicians and also for your clients and patients. The effects can last up to 12 weeks, 12 weeks, 12 months after the intervention is over. They're comparable to cognitive behavioral therapy for stimulants in research. And does everybody stay abstinent again that whole 12 months after we stop doing the contingency management? No. But are they more likely to be abstinent than people who don't receive contingency management during that time or have lower use? Yes. And then because Sarah and I do so much work in alcohol and using contingency management as a tool for alcohol use disorder, we're focusing on stimulants with you all, and that's what the state's supporting you all in implementing, because we have such a problem with methamphetamine use disorder and stimulant use disorder in general. But we also want you to know this is an effective intervention for alcohol use and for tobacco use as well. So okay. So now to get a little geeky on you, we're going to talk about the research. So there's been a bunch of meta-analyses. That's where we do like a study of all studies. So we bring somebody, not me, some statistician brings together all of the data from all the different randomized trials that have been done on a treatment, puts them together, and then looks at their outcome or compares their outcomes and their efficacy across all those different studies. So there's been 4 or 5 recent contingency management meta-analyses, and this is just one. This is one that was published this summer, and the reason I wanted to share this one with you all is because I know all of you, or almost all of you, are providing care to people with MOUD. So people who are receiving medications for the opiate use disorder. There's been 60 studies that have found contingency management is effective for treating comorbid or co-use of psychostimulants in people who are receiving MOUD. 60. So that's a ton of evidence, right? We're going to talk about later, well, why have we been doing this for 20 years? That's a great question, and we'll talk about that later. But I want to share with you that not only is contingency management very effective for people's stimulant use disorder if they're receiving MOUD, either methadone or buprenorphine, but we have a large effect size. So we talk about this term effect size, which if you hang out with any psychologist colleagues that are on the call, or you might know, or have done research before, or you really like this kind of stuff, you might know what an effect size is, but for most of us, we don't. So an effect size is it's different than like statistically significant. So like 2 groups are statistically significant. That tells us just that they're above chance different on an outcome, like let's say abstinence. What an effect size tells me as a clinician in the patient I'm working with, it tells us how likely it is to have a benefit to them. So not just compared to, it's how likely is this going to change my outcome, and how big of an impact is this going to have on the outcome that I care about. So in psychiatry and psychology, we typically see, like for a cognitive behavioral therapy, an effect size that's in the small to moderate range. And that's an effect size of like 0.4, 0.5, and 0 being the smallest effect, 1 or higher being the best effect. Like it's wonderful, changes everybody's lives. We see with contingency management is an effect size on stimulant abstinence in this meta-analysis of 0.7, which is a large effect, and is very rare that we see an effect like that in research, especially for substance use disorders. So contingency management take-home point really works, especially for stimulant use disorders. And in particularly, there's been 60 studies demonstrating that for folks who have MOUD or are receiving MOUD. The other things here just really quickly are some other effect sizes or outcomes that contingency management is associated with, again, in people who are receiving MOUD. It's also adds additional benefit to buprenorphine or to methadone in terms of illicit opioid abstinence. It reduces smoking. There's a myth in our profession that if you reduce one substance use disorder or use of one substance, another substance goes up. So if you stop smoking, you drink more, or you drink less, you start smoking more. Dr. Miguel, who's on the call, has done lots of studies as if we showing that's not the case. When you reduce one drug of use, you usually reduce other drug use as well. There's also an effect on therapy adherence, reductions in substance use, and improved medication adherence. So contingency management has a lot of benefits when we target stimulant use, and it has these side effects on these other outcomes as well. So that's the meta-analysis, like that's a reasoned study of all studies. And so now I'm going to pull out a few studies and just talk about the results specifically. So this is a study that was conducted, a multi-site study across the whole United States. These are all folks who are receiving, I think, methadone. There, this says in the table, methadone. So these are people who are in methadone treatment, and they also have a stimulant use disorder, either cocaine use disorder or methamphetamine use disorder. And they're being rewarded in this study with that prize-based contingency management. And they're receiving those rewards for submitting a stimulant abstinent sample. They could also get an extra reward for alcohol samples being negative. And so what we find here is 4 weeks of abstinence in the CM group versus the usual care group. The odds of having 4 weeks of abstinence, the contingency management groups, their odds of having that level of abstinence 4 weeks or more is 3 times higher. When we look at 8 weeks of abstinence, which is a big deal, right, in our work, we see that contingency management was 9 times more likely. When we look at 12 weeks or more of abstinence, we see that the contingency management group is 11 times more likely. And I'm not going to oversell this product of contingency management, because you can see that still only about 5 or 6% of people who receive contingency management are abstinent the whole 12 weeks, which is, again, this is a 12-week study. So there's evidence that our contingency management here in this specific study really improves abstinence, levels of abstinence, especially clinically meaningful levels of abstinence, the odds of having those. But is it perfect? Is it a cure? No, just like no other interventions we have right now are. But it's a powerful tool that can really improve outcomes. This is an interesting study. This is one of the first studies done of contingency management for stimulant use disorders, done by Dr. Higgins, who created the voucher model of contingency management. And this one's important because it compares community reinforcement approach, which is the control treatment. It compares outcomes of folks who have a cocaine use disorder, who either receive community reinforcement, which is an evidence-based intervention for addiction, or a group that received community reinforcement plus contingency management, and the voucher model of contingency management. And what Dr. Higgins and colleagues found was the 2 outcomes that I mentioned at the beginning that we really care about, we do see an important effect of contingency management on. The first one is on retention. So the incentive group here, or the contingency management group, was about 75% of them were retained through the whole intervention period. Whereas the group that just received community reinforcement was less than 50% of them were retained. When you look at 8 weeks of cocaine abstinence in this one study, we find that people who received the incentives in addition to CRA, that they're about 60 to 70% of them are abstinent for 8 weeks or more. And whereas only about a quarter people in the community reinforcement only group. So here's a good example of a study that shows how CM can improve the benefits of an evidence-based intervention like community reinforcement for stimulants. This is another study that we did, and I'm showing you this first slide, but it's really the next slide that I'm going to show you that I think is important. The folks that you saw in that video were participated in this study. This is a study where our team thought, well, what if we brought contingency management to a community mental health center? So a lot of people who go to community mental health center, people who live with bipolar disorder or schizophrenia or really severe depression. 40 to 50% of them will suffer from a substance use disorder at some time in their life, or experience a substance use disorder at some time in life, and they might not have access to that care. What if we bring in evidence-based intervention to those folks who have co-occurring disorders? So in this study, we're rewarding people stimulant abstinent. These are all people with co-occurring disorders. We're reinforcing their stimulant abstinence. And what we can see here is that the control group, which we call the non-contingent, those people just get rewarded for showing up. Their abstinence is around 60 to 70% of folks that are abstinent in any given week, but we see almost 90 to 100% abstinence in the contingency management group. It's an abstinence level that's 2.5 times higher or so in the contingency management group, which is very consistent with people who don't have co-occurring disorders that receive contingency management. So what's exciting though about that study, and the reason it was an important study, is that we showed that it would work, and could help people be more likely to be abstinent if they had a stimulant use disorder. But what we also found was a big difference in inpatient psychiatric days, number of people hospitalized for psychiatric purposes, and number of days hospitalized. So this is 6 months before people were randomized, those two little bars here. And then on the other side, I want you to look at these are number of days and number of people hospitalized across a 6-month post-randomization period. So what you can see here is a large difference. This is the control group. They were hospitalized for a total of 152 days versus the contingency management group only hospitalized for psychiatric reasons for about 14 days total. So what you can see in this study, and there's been another study that's replicated this, we can see that if we use this humble little intervention, these incentives to help people cut down their stimulant use, we can see a big difference in things that really matter, like inpatient hospitalization days. Okay, so that's an overview of some of the research. We want to talk about cultural factors because culture is really important. Like a lot of other substance use treatments, when we developed them in the 90s and even in the 2000s, we didn't often partner with the communities that we served, or that the interventions were designed for, to culturally tailor them or really make sure they reflected their community. But people like Andre have been doing this work for a long time across the world. And so what we've found in contingency management is tested in Brazil by Andre and his team, in large studies in China, other places around the world, and there's no evidence that it's differentially effective for specific cultural groups, that it's less effective for certain groups. Our team took the extra step in the last 10 years in partnership with Native communities throughout the West, and we conducted 2 community-based research studies where we culturally tailored contingency management, the prize-based model we're talking about. We culturally tailored it specifically to meet the needs of the Native communities we were working with. And these studies were focused on alcohol. Both of them were focused on alcohol abstinence, using contingency management to treat alcohol abstinence. One of them was focused on alcohol and other drugs. And we found in both those studies that our culturally tailored model was really effective at improving abstinence from alcohol and stimulant use. And we also found that if we reduce people's alcohol use, they reduce their stimulant use as well, even if we weren't targeting stimulant use in one of the studies, and they also reduce cannabis use. So we found that some of our cultural adaptations were focused on the family interventions, family incentives, as well as focus on providing transportation and sort of addressing social determinants of health. So we want to talk a little bit about that. We have a whole separate indigenized model that we have available to train folks in. But we really want to talk about culture because it's important. And I think the more we think about substance use, the more we all are thinking about social determinants of health. So Sarah, any questions so far? I don't see any.
No, I didn't see any questions. So yeah, please feel free to chat out questions if you have any about what Dr. McDonald just shared. We'll keep going though in the interest of time. We only have about 20 minutes left. So I did want to just introduce, after all this great research in, environments where they were grant funded, and, in research we get to, kind of control certain factors in a different way than we call the quote unquote real world. And so the VA was the first to roll out contingency management on this large scale real world implementation. And so, but they did rigorously collect data on it so that we can see how well it worked in that setting. And it just, I had to read this twice. I thought that the outcomes were so good that I wanted to make sure they were real. And I looked into it, and boy, this is impressive. So 94 VAs have implemented contingency management. What they found is that people attended more than 50% of their contingency management sessions. And when they did, 91% of those urine drug tests were negative for stimulants or drug negative. And so this is great. Shows that it's working in setting in a variety of settings. That means a variety of providers were doing the contingency management and really getting some great rewards now, or great outcomes with the rewards. Now, some key differences between what the VA was able to do and what we're going to be teaching, what we, Mike mentioned, we've been teaching in Montana and now in Washington, what California is doing. The VA does have its own kind of special setting. They don't have to worry about Medicaid billing, and they don't have to worry about where their prizes are coming from, because they used their own Veterans Canteen services to deliver the rewards. And so we still have more problem solving and adaptation to do to be able to take this model into all of the variety of settings that you all will be doing contingency management in. And if you could move on to the next slide, Mike. And also, it's always nice to follow research, numbers and statistics that make us feel good about it with what do actual clients say about contingency management? Do they like it? Is that, that almost feels more important to us sometimes. And so here are some of the quotes that have been collected, when we've done some of this research. When I'm at home, I see the prizes and I think, hey, I got these for staying sober. Somebody said something, something to do besides thinking about everything wrong with the world, being negative. It gave them a little peace of mind. Those visits themselves can be just really fun little 5 minutes in your day, even as a provider, 5 or 10 minutes, because you get to have such a positive connection with your CM clients and patients. Another person said, I don't care about the prizes, seeing myself get clean, it helped me. And so the prizes may just be a vehicle to kind of help them start to feel those natural rewards for, for achieving more and more abstinence. And then I still wanted to be clean, even though I knew it wouldn't be held against me and it wouldn't be shared. I was conscious of that. So people actually, know that if they do show up and have a positive urine drug test, that they're not going to be shamed for that. They're just going to be encouraged to come in next time. And that feels very different for people who have UA'd a lot and are just waiting to get in trouble. The flipping that whole system on its head and celebrating urine test results instead of punishing them is noticeably different for some of the people who are walking in your door. And then some people said it gave them something to look forward to, a schedule. So that structure, coming in twice a week, we sometimes think of that as a negative. Oh, that's really hard to do. But that consistency and being able to build relationship 24 times with somebody it's great. And, I could share tons of stories about what people have shared with me. I know one more but in the interest of time, I won't do too much more than that. But one more is, I love how one of our contingency management participants let us know that he was a gentleman who was struggling with getting housed, and so was experiencing homelessness at the time. And he used his rewards to buy some cologne and buy a nice jacket. And he said, I don't feel homeless anymore. And he liked to present himself in a way that really felt good to him. And so it's not just about a material good, right? It's about what people do with those rewards can feel fulfilling on levels that we may not have initially even think about. So with that, I'm going to pass it back to Mike so that he can finish up with some of the challenges, and then we can still take some questions.
So thank you, Sarah. Yeah, we have so many fun. Again, we don't want to oversell it. It's not going to cure stimulant use disorder. But man, is it fun to do contingency management. And it's really great to have these kind of stories. And we just did our training in person in Montana last week, and we heard some just amazing stories from some folks. And also, but they also talked about challenges. So let's talk a little about challenges. So the first one is staff resistance. When I started doing this work with Dr. Rick Reese and John Roll, who's over here at WSU, Rick is at UW, when we started doing this work at community health centers and substance use agencies, people said, what? No way. I had people storm out of the room, threaten me, clinicians, not patients, saying this is just not, we can't pay people to be sober. That's wrong. And so we really found that just like buprenorphine, people's initial concerns about buprenorphine, and those, they still are there, but especially in our field, people are getting on board with this idea. What we all care about as clinicians is patient outcomes. We care about how our patients are doing, how their lives are changing. And we love to see change, right? That's what we're all driven to see. So usually those are overcome by folks being there. We're here to support you with those when you talk to administration, or you talk to outpatient providers, or other folks who maybe don't feel comfortable. Of course, not every patient's going to feel comfortable with this treatment option, and that's fine. We really want to give patients what they want, so we respect that too. But that tends to be very rare. The number one challenge is the challenge that you all shared before, which is how do you track the rewards? How do you track how much a person's supposed to get in a particular time? That's the most challenging part of contingency management. And we've got a tracker, and we've got a manual, and we've got ongoing technical support to help you with that. So we've got your back on that, and HCA is finding the funding to make sure you can do this intervention, which hasn't been true in the past. Not HCA in particular, but nowhere else outside of the United States, outside of the VA, has really been able to do a large scale statewide implementation of contingency management. And the reason they haven't is because of Medicaid kickback rules. So a lot of us have heard of the Stark rule. If we've been, all of us who are providers and we've received some sort of Medicaid compliance training, so the anti-kickback rule is I can't send Sarah a patient as a referral and then her send me $50. That would be a bribe, right? That would be not allowed. And what was happening in California during the 2000s, where clinics were advertising these big billboards saying, hey, Medicaid clients, come in, get a free health evaluation. It's covered by Medicaid. We'll pay you $100 to come in. So they come in, they'd run up all these really expensive tests on those folks, and they bill that were medically unnecessary. They bill Medicaid in billions of dollars of fraud. So there's contingency management, a humble little intervention that really works for people with stimulant use disorders and other folks with drug use disorders. And then there's billions of dollars of Medicaid fraud. And Medicaid said, until the last month of the Trump administration, they've said, please, be careful. No, we don't really want to encourage that intervention. But the good news is, in that last month of the Trump administration in December of whatever year that was, some year, maybe before the pandemic, maybe not, I can't remember, in the pandemic, the CMS and the Office of the Inspector General, who's like the Medicaid police, basically, and they make the rules about how incentives are allowed to be used in Medicaid. They said, hey, look, we know this is bad. We know that what's happening is not okay. We need to help people. We know contingency management is the really only effective intervention for methamphetamine use disorders. And so we want to make this something you can do. We're not going to give you what's called a safe harbor to just do contingency management, just wave a wand and say it's now legal and you won't get in trouble if you do it. But we're going to make a few other rules. And if you follow these rules, you can do it with Medicaid and Medicare clients. So the group we don't talk a lot about is Medicare, but this applies to Medicare as well. So the rules are you cannot advertise. You cannot go out and put up a billboard in Puyallup that says, we're giving people prizes to stop using drugs. You can't do that. You can tell people about contingency management, what it is, that it's part of your program. You can, of course, have brochures on it that you'd share with providers or with interested patients, but you can't go across and just advertise it and make it look like you're trying to make a profit. So that's number one. I don't think any of you are going to do that. You have to document the need, just like any other intervention. You need to document the need for contingency management in your treatment plan. This individual has a stimulant use disorder. Therefore, we're using an evidence-based contingency management intervention. So you need to have that documentation in your treatment plan. Again, we're going to support you and help you come up with some policies and procedures to do that. It would help you protect you from a Medicaid audit if one ever would happen, if you used a research-based program, not a program you just made up yourself. If you said, hey, these folks who are researchers, who are experts in contingency management trained us, we're using the model that's been vetted by the healthcare authority here in Washington, that's going to protect all of us from an audit if it ever happened. You want to carefully document that you are giving out gift cards, not for a billable encounter, but for the provision of a stimulant negative urine test. So right in healthcare, we are moving towards a system slowly but surely that pays and reimburses providers for positive patient outcomes. CMS, everyone's happy about that. So if you write a documentation, a note, or and it says that this person is in contingency management, they submitted a negative urine sample and they got $20 in gift cards, that is focused on a patient outcome. We're encouraging you not to write a note that says, we did an IOP session today, an intensive outpatient session today, which I'm billing for, and I gave people a $20 gift card for attending. That could be construed as potentially a kickback or violating this rule. So we're really, that gift card tracker that we'll be sending you later this week is really the way you can document that in a tangible way, and then also include some documentation in medical record. We don't want you right now to ever exceed $599 worth of incentives over a tax year, and that's because because that person will have to report that on the income tax. So we want to try to avoid that. That's why we think that around that $500 is a sweet spot, because we don't have to worry about income tax, because some people are not happy when we go over that threshold, clients and patients. You want to also evaluate and do some QI, which that tracker will help you with. And the big take-home point is really avoid tying this the incentive to a Medicaid billable encounter. We'll talk more about that next week. I'm glad to answer questions about that, but we'll talk more about that next week. So that's why it's important we're working together, because we are breaking ground here. We are doing something that until a couple of years ago, less than 18 months ago, was not allowed. We are now allowed to do it. California has received a waiver from Medicaid that says they can go for it. They can do it. They can use Medicaid money. We haven't done a waiver, but the HCA stepped up and said they're going to support us in doing this. And it's really important that as we do it together, we do it really well, because this whole national spotlight is on us. Whether it's the Biden administration spotlight, the media, I can't tell you the number of media requests I get every week to talk about contingency management. The media attention's on this, both on most 99.99% a good way. But there's media attention on this idea that we're paying people to stop using drugs as well. So we want to do this right. We really want to do it right. So we've got all these things that we're offering you all in the next few weeks or months, years, that we're hoping to collaborate with you all on. And we really want to thank, again, HCA and our colleagues at ADAI for partnering with us on this, and you all too. So I think we have about only 5 minutes for questions, remembering that we'll definitely be here and have your back to answer questions as we go. But if folks have any questions, either unmute yourself or go ahead and just speak up. I know we have a big group, so we might have to, if you've got questions, please either raise your hand, speak up, unmute yourself and speak up, or chat your questions.
I have a question.
Go for it.
We've attended other trainings in the past that did kind of suggest that we could, kind of alter the contingency management program to target different behaviors.
Mm-hmm.
So basically meaning that we didn't have to have it tied to a UDS,
Mm-hmm.
because in our clinic, we have multiple clinics throughout the county. And so we have one OTN program based out of OMAC. So it would be really hard for us to, I guess, keep track of all of the patients at every clinic, at every site, and their UDS. It's much easier for us to track attendance, and that is the behavior that we have been targeting.
Mm-hmm. That's a really great question. And I think we are glad to talk some more about this in detail, because there's some issues around maybe your funding and some of the other programmatic issues that might be, that we might need to work out. I could tell you that we've been doing something very similar in Montana with teams, and we've figured out a way to work it out, especially in the rural communities that we work with, because all those communities are rural. So the main thing here is that for this contingency management training and implementation we're doing, the target is going to be the urine drug tests. And we can be creative though about how we do that. And that's the reason that we're doing it that way is, one, because again, we're breaking ground. The evidence is mostly for, well, there's evidence for all this for attendance. but the evidence is really strong for abstinence in the urine drug tests. And then secondarily, that this really, we want to be careful about the Medicaid compliance thing. So I think, we've talked with other colleagues, including some folks on the call, about the idea of reinforcing attendance. And that we now know that we probably want to be cautious about that in the next couple of years. I'm hoping that there'll be some federal changes that will allow us to do that. But we really want to be cautious about reinforcing attendance to a billable encounter. So if you're reinforcing attendance to another, like a visit that you're not billing for, then that's totally fine. That's not what we're going to be teaching you all. And we're totally committed to working with you to figure out a way that we could help you feasibly implement this. Other sites, we had this issue come up in Montana. We've talked about, although we're not saying we're doing this yet, but there's saliva samples that we can gather from people over video. There's other ways that we can do the biomarker stuff that wouldn't have to necessarily be the urine test. But Brianna, we're committed to figuring it out with you all and learning about each group's individual sort of unique needs.
Yeah, hopefully we'll be able to dig into those during some coaching calls that we'll be having as you all are implementing, and we will give you some tools and focus on those point of care urine drug tests to hopefully make that seem a little less intimidating than it might seem right now, and have it be a more feasible method. And somebody also chatted a question: do we ever discharge patients? So that's a good question. And in terms of whether you have to do that, no, and they do have a 12-week period where they could have spotty attendance. And if you can continue to use some of your staff time to re-engage participants, or clients and patients, we recommend that. And we know that, there is some bandwidth issues and you're trying to see what's the best use of your time. And so you could, if you haven't heard from someone for a little while, you may consider them, you may have a policy of like, okay, this 12-week period is over for them, but if they do re-engage, I may be able to just start from the beginning again. You will have to be mindful about not giving out more than the capped amount, which is we'll teach you next week, but say it's $500 in that calendar year. So you don't want that person to end up, dropping out right at the end of their 12-week period, restarting from the beginning and earning more money than you have budgeted for them. But we definitely do encourage trying to keep people engaged, even if they've missed some appointments. So hopefully I answered that. I know it's 2:30 already. Was there one more question in the chat? Oh, no, just a comment. Okay, and save up those questions. We hopefully will answer them in the materials we present next week, but also you can ask them next week if something occurs to you later. We're also still, I apologize, the survey, the contingency management knowledge survey is a little bit tricky because you have to do the demographics and then get emailed the survey. And then we're trying to change the timing of when you get a post-survey test. So if any of you all get basically that same quiz again in about an hour, hold on to that. We're getting, go ahead and fill that out after next week's presentation because you'll learn more then. But hopefully we've made some last minute changes where you won't even get that post test until next week. So feel free to email Mike or myself if you have any questions in the meantime, and we will get you those materials to look at hopefully by end of day tomorrow at the very latest on Monday. So you have time to look at it before Wednesday. I also apologize for the typo in that one slide. The nuts and bolts training is on February 9th. Which is next Wednesday. I just double checked my calendar.
And I said it was like Thursday or something. Or
yeah, you said Thursday, the slide said
Wednesday.
Tuesday.
Everybody
Split the difference, it's on Wednesday.
Next Wednesday, for those of you who aren't able to make it, we will be recording it. And remember, again, we'll have ongoing coaching calls and to follow up with you all. And make sure that everyone does, if you haven't chatted for attendance purposes, please chat in your organization and your name if you haven't had a chance to. So thank you, everybody. I know that was a whirlwind, sort of really quick overview. I appreciate everyone's attention, and especially during these COVID times. So we're really excited about working with you all, and we will see you next week.
Bye-bye.
You.
Thank you.